Hello and welcome to our attendees here in the U.S. and around the world. Thank you for joining us for today's Nova Biomedical webinar, Best Practices for Managing Sepsis and Septic Shock, including the use of ePV. Our speaker today is Dr. Devang Sangavi, Associate Professor of Medicine and Director of the MICU at the Mayo Clinic in Florida. Also presenting will be Dr. Dennis Bagos from Nova's Medical and Scientific Affairs Department. Dennis will discuss estimated plasma volume assessment in critical illness. I'm Rick Rollins, Senior Marketing Manager at Nova, and I'll be moderating today's event. If you want to join in on the discussion, you can post questions during the webinar using the Ask a Question tab on your webinar console. We will address all questions following the main presentations, and a full list of questions and answers will be provided to you soon after the webcast. This webinar has been approved for 1 contact hour of PACE continuing education credit and 1 CERP unit by the American Association of Critical Care Nurses. You can obtain your CE certificate by completing the post-webinar survey that will be sent following the conclusion of the webinar. If you fail to receive the survey, please be sure to check your junk mail folders in your email system. You can register for future live events on the Nova website and explore our broad library of on-demand content with topics in clinical testing, cell culture, and veterinary diagnostic testing. Be sure to subscribe to receive notice of future Nova educational webinars. You can also find more information about whole blood critical care testing products on the Nova website. And now to our main presentation. Devang Sangavi is Vice Chair of Critical Care Medicine and Medical Director of the Medical ICU at Mayo Clinic, Florida, with a joint appointment in the Department of Transplantation. He holds the academic rank of Assistant Professor of Medicine at the Mayo Clinic College of Medicine and Science and is chair of the Sepsis Work Group. Dr. Sangavi is passionate about caring for complex, critically ill patients involving transplantation, ECMO, MARS, and COVID-19. His areas of interest are post-ICU care syndrome, EICU, ECMO, and healthcare technology. He specializes in healthcare delivery and innovation through a multidisciplinary team approach. Please welcome Dr. Sangavi.
Thank you, Rick, for the warm introduction. I'm Devang Sangavi, one of the intensivists here at Mayo Clinic, Florida. I'm Associate Professor of Medicine, and I also serve as the Chair of Sepsis Committee. Today, I'm here to talk to you all about sepsis and septic shock. We will discuss some of the controversial aspects of taking care of septic and septic shock patients. And I'll share my slides now. So I'm going to talk to you all about sepsis and septic shock. While talking about that, we would try to get an understanding of key updates and the controversy surrounding sepsis and resuscitation, and then review recent articles related to trials and how do we apply that to our current practice. Some of the controversial topics that I would try to tackle today we'll start with the very definition of sepsis. Then we'll tackle whether SEP1 metric really matters. In that, we would break it down by timing of antibiotic administration. We'll talk a little bit about markers of perfusion, that is lactate versus mixed venous saturation. Then talk about fluid resuscitation, crystalloids versus colloids, 30 cc's kgs per kg or less amount of volume. Then we'll also talk about volume status and how do we assess for volume status. In that, I'd like to talk about estimated plasma volume status, which is an up-and-coming area where I've worked a little bit and would want to mention that. Also talk about timing of pressor initiation and whether we can give pressors through a peripheral line. In the last few topics, we'll talk about culture negative versus culture positive sepsis. How do they do in terms of outcomes, use of midodrine, and then how do we identify patients with sepsis in an inpatient setting, and what is the role of AI in that? So without any further delay, let's start with the very definition of sepsis. As things stand today, there are three definitions of sepsis that we are all aware of. The established definition, which is followed by the CMS, follows the SIRS criteria. Then there is the SEP3 definition, which has been around for the last 7 or 8 years, which uses SOFA score or SOFA criteria. And then the recent surviving sepsis guideline came up with their new definition. So which definition do you follow in your institution, and how does that do in terms of the actual outcomes of your patients? At our institution, we follow the SIRS criteria, the definition established by CMS. We are all aware of that. That has been around the most. It kind of breaks it down by sepsis, severe sepsis, septic shock. SEP3 definition came about, as I mentioned, 7, 8 years back. There is a controversy regarding its performance in correctly identifying septic patients. And although several institutions use it, the question or the concern about its sensitivity and the specificity kind of has decreased its usage overall. And the surviving sepsis guidelines actually, irrespective of the definition or the screening criteria, it took away severe sepsis and just kind of keeps sepsis and severe sepsis as similar, and then also includes shock, which is sepsis, which is refractory to fluid resuscitation in terms of blood pressure. If the patient is hypotensive, then the patient has septic shock. So let's look at data. And while discussing SIRS criteria versus the SEP3 definition, want to show two papers which are kind of showing data for both these criteria. One which is showing SIRS criteria, which has slightly better performance as compared to QSOFA, and then the other one, which is the paper which shows QSOFA doing slightly better. So the first paper that I want to share is the one which was published a few years back. This is a study done in Japan, actually, and they actually compared SIRS criteria to QSOFA score. And as you can see on your screen here, there are two graphs, graph A and graph B. And the red line shows the SIRS criteria's performance and the area under the curve for that. And then the chart B shows the performance of that in terms of outcomes, specifically to mortality. And as you can see, SIRS criteria actually does better in terms of area under the curve as compared to QSOFA. These were 1,000 or more patients in this analysis, and this actually favors SIRS criteria. Now, moving on to the second paper that I want to show you, this was done in Europe. This was done in 2021. And they actually also used SIRS criteria and QSOFA and divided their patients into 5 groups. The first group was SIRS positive, QSOFA negative. Second group was SIRS positive, QSOFA negative. And the third group was both SIRS criteria positive, QSOFA positive. Fourth group, SIRS negative, QSOFA positive. And the fifth group was SIRS negative, QSOFA positive, and then treatment in terms of SEP1 metric. And as you can see that in this particular study, the primary endpoint was to look at inpatient mortality, in hospital mortality, and ICU admission. And the group which actually tend to do better here was the one which is shown in the green bar, which is SIRS positive and QSOFA negative with the treatment arm, which is compliance with the SEP1 criteria. So the results here kind of show that QSOFA performed as well as SIRS criteria, and in terms of the overall in-hospital mortality and ICU admission. So in a way, what I tried to show was that one paper wherein the SIRS criteria patients were performing better than the QSOFA, And in the second paper, which is out of Europe, QSOFA and SIRS criteria kind of did equal. So the jury is still out there. To me, the criteria in terms of screening the patient should be more inclusive. And to me, SIRS criteria seems to do a better job than QSOFA in that aspect. You may have more false positive patients, but upfront, you don't want to miss patients when you're screening somebody for sepsis. The most important part here is that identifying them and providing them with the appropriate treatment, which is what would are shown in this graph here, wherein the treatment that was provided based on the SEP1 metric actually did the difference. So what is SEP1 metric? You all would be, if you're taking care of septic patient in an inpatient setting, aware of SEP1 metric. But let's briefly review it. So CMS SEP1 metric requirements say that if you have a septic patient who has severe sepsis, they break it down into a 3R bundle and a 6R bundle. So what these bundles essentially include is you want an initial lactate collection, you want blood cultures, you want appropriate antibiotics started, and then if the lactate is positive, that is an abnormal value, you want a repeat lactate following in the 6R bundle. If your patient, after the initial fluid resuscitation, is still in shock, they want you to, in the 6R bundle for the septic shock, start vasopressor, and then you also want a volume status assessment done within the 6 hours window. So this is what essentially all our hospitals are tracked in terms of performance. How did we do for severe sepsis and septic shock patients? The 3R bundle, the 6R bundle. Right now, this data is available for all hospitals on the CMS website. And in future, the reimbursement for a hospital for performance of septic patient would be tied to this bundle. Now, you may say, does this truly change mortality? Following components or compliance with the SEP1 components, does it truly change mortality? So again, I'll show you two papers. This is a paper published in Chest in 2022 by Townsend and group, which actually shows you that this was a big data, 3,200 plus hospitals. The data was accrued from October of 2015 to March of 2017. And the compliance to SEP1 component was kind of something that was included in that. And completion of all components of SEP1 metric was the primary defined term. And what they did was break it down into hospitals data, which showed patients who got treatment based on the SEP1 components, and they were compliant or non-compliant. And you can see that the 30-day mortality between the two groups, the compliant group and the non-compliant group, was statistically significant, showing that by standard matching and then stringent matching, both showed a stark improvement in mortality with SEP1 compliance. So essentially, this data shows that if you approach a patient in an organized way, that is, if your patient is septic, you identify it early, you do care of that patient in a very step-by manner, you would certainly have improvement in terms of mortality. Well, there are some controversial aspects of SEP1 component, and I'll get to that later. This is another paper which was published around the same time. This was published in JAMA 2021, which also looked at compliance of the septic patients' management based on whether they followed SEP1 metric or not. And here, the outcome of interest was in-hospital death or discharge to hospice. In-hospital death was the other thing in this graph B. And you can see that, the key findings here that the non-compliant versus the compliant group, and this this blue line is the time wherein the CMS mandate for SEP1 compliance kicked in. So that's how you see this two different groups being broken down into. And just visually, you can appreciate that there was not much difference in terms of mortality here. And again, this was data from multiple thousands of patients, and compared to the other paper, there were enough number of patients, big enough sample size to kind of say that maybe, like, SEP1 compliance itself may not have been the difference. Protocolized approach to taking care of septic patients may have led to better outcomes. So jury is out. At our institution in Florida at Mayo Clinic, we follow the SEP1 metric. We follow the septic patient in a protocolized manner. We have a sepsis response team, and we try to follow the components of SEP1 metric. And if we feel, based on our assessment, that a patient doesn't need fluid, we try to document that by an exception of phrase that we enter in our notes, so that the idea is not to give all the patients 30 cc's per kg fluid. There are certain groups of patients who require fluid, maybe not 30 cc's, maybe less, maybe more. The key is to individualize their care. So coming to different components of SEP1 metric, the most important and probably the least controversial of the SEP1 metric is antimicrobial use. And I want to impress upon the audience here that early and appropriate antimicrobial use saves life. And to illustrate this point, I want to take you back almost 18 years now. This paper, published in Critical Care Medicine in 2006, actually shows you how effective an early antimicrobial use would save life. This was old study, but some minor in its work, which actually shows you that with each hour of delay in use of appropriate antimicrobial use, there is an increase in mortality by 7.6%. And that, in this day and age, we cannot afford. So identifying patients with sepsis and starting early and appropriate antimicrobial use is crucial. And what do I mean by appropriate antimicrobial use? I'll show you in the next slide. So to illustrate that, I want to share this paper published in Chest in 2009, wherein they broke down the entire group of patients between whether they received appropriate antimicrobial therapy or whether they received inappropriate antimicrobial therapy. And in all comers, all patients, that is total of 5,715 patients, if the patient received appropriate antimicrobial therapy, the outcome, which was mortality, was significantly better as compared to if they received inappropriate antimicrobial therapy. And now breaking it down to whether they had culture positive versus culture negative, same thing, the p-value in terms of receiving appropriate antimicrobial therapy was significantly better as compared to inappropriate antimicrobial therapy. And you can go down the list here, whether the patient was bacteremic or not bacteremic, whether they had community-acquired infection or nosocomial infection. Getting appropriate antimicrobial therapy was key in terms of their survival. So what I'm trying to illustrate here and impress upon you is that timing is everything as far as antimicrobial usage is concerned. And empiric broad spectrum coverage and covering for MRSA, Pseudomonas, and Candida is key if the patient has that history. So that is essentially the principles of antimicrobial or antibiotic coverage for your septic patient. Obviously, getting cultures before you start antibiotics is pivotal in terms of getting better yield from your blood cultures. But if it's difficult to get the blood cultures, I dare say that you start antimicrobials and don't waste time trying to wait for the cultures because every hour matters. As we saw, there is an increase in mortality by almost 7% with each hour delay in getting appropriate antimicrobial therapy. As far as markers of perfusion is concerned, the second component in the SEP1 metric is lactate. And if the initial lactate is negative, then there is a mandate or need for repeat lactate. So what are our options? I know there are believers for lactate, and then there are people who don't like lactate because it's not a perfect science in terms of getting accurate assessment of perfusion. But to me, this is the best we have so far as markers of perfusion is concerned. And there's some data to support that. So from early goal-directed therapy from the seminal paper by Dr. Emmanuel Rivers, mixed venous saturation was something that we all used to do in terms of taking care of septic patients. But this paper published in 2010, which was kind of comparing lactate group with the mixed venous group. It's a small paper, but for a critical care study, it had 150 patients in each arm. And what they actually did was try to either target lactate clearance in one group or measure and monitor mixed venous saturation in the other group. And when they compared outcomes which are relevant to us, that is the inpatient in-hospital mortality, then the length of stay in ICU or the hospital, ventilator-free days, multiple organ failures, all of those were similar in both lactate group and the mixed venous saturation group, essentially saying that for mixed venous saturation, that may require, that is especially the continuous mixed venous saturation, may require a special catheter and ongoing monitoring. Lactate is probably simpler and maybe cost effective. And the outcomes, if you compare head to head, there was no difference. There is this meta-analysis, which also kind of points towards lactate being a better guide in terms of resuscitation. So if you look at lactate-guided care versus early goal-directed therapy, you can see here on the plot that the lactate group actually tend to do better. And you can see the total number of patients in this 5 to 6 studies that this meta-analysis used. So the total patients are around 336 patients in one side, and then the other side had 311. So there is enough evidence to say that in absence of any other alternative strategy, lactate probably is your best bet in terms of trying to understand the resuscitation status and the perfusion of your patient. And at our institution, again, we follow that. We try to get the lactate early, and then if it's elevated, we repeat it and try to see if it clears with the resuscitation that we provide. Now, changing gears and looking at IV fluids, and this has been an age-old question: is like how much IV fluid and which IV fluids to give. This, to me, is the most controversial part of our SEP1 bundle, and there have been numerous studies comparing balanced crystalloids to your normal saline. Colloids have kind of taken a step back, although they remain a key important ingredient in terms of resuscitation in certain patient population, and how much to give. And so trying to look at that in a more balanced way. So the first study that I want to show you, which kind of favored balanced crystalloid, was the SMART trial published in March of 2018. This was done in the ICU setting at 15,000 odd patients, divided into two groups. One group which had close to 8,000 patients and received balanced crystalloid versus the saline group, which had 7,800 odd patients. And what they actually showed is that the composite endpoints, that is in-hospital mortality, need for new renal replacement therapy, and incidence of persistent renal dysfunction, the composite endpoints was better in the group which received balanced crystalloid. Now, you may say that in real world, we don't follow composite endpoints, right? To us as clinicians, we care about mortality, we care about need for new dialysis or persistent AKI or kidney dysfunction. Trying to club together those three things is not a real world endpoint, although trying to combine that, they actually had set it out as an endpoint early in this design phase of the studies to give credit to this group. So for a while, our practice was to give balanced crystalloid to the patient as compared to saline group, because that also made physiological sense. There is this SALT-E trial, which also was published around the same time, published in New England Journal of Medicine. This was in non-ICU patients, and they also did the same thing. They had a composite endpoints looking at kidney dysfunction, need for renal replacement therapy, new renal replacement therapy, and then mortality. And they also found evidence to suggest that patients who receive balanced crystalloid, that is LR or plasma light, did better as compared to saline group. So for a while, the practice was to give balanced crystalloid. That changed when BASICS trial, which was published in JAMA, this came just around COVID time, which actually was the biggest such trial with a total of around 5,200 patients in both groups. And the balanced crystalloid that they used was actually plasma light, which many consider as the most superior of the balanced crystalloid. They compared that to saline solution as the comparator arm, and their endpoint was death within 90 days, that is the 90-day mortality, and they did not find any statistical significance between the two groups. So now you're back to square one, wherein some would say that physiologically saline is harmful and resuscitation in large quantity of fluids when you give it to the patient because of concern for non-ion gas metabolic acidosis, hyperchloremia that it causes. But when you try to study that in a real world, the evidence is kind of iffy. This study, which was the most recent, actually showed that there was no difference in terms of mortality in these two groups. So the jury is out there. We tried to use balanced crystalloid when we are giving more than a couple of liters of fluid to a septic patient in our practice, just because that makes physiological sense. But evidence, as I showed, is out there. So where does our data show? This is something that we looked in our practice. We compared, this is a retrospective work of our enterprise data, wherein our septic patients, we based on the fluid that they receive, we kind of looked at whether they receive normal saline versus LR. And you can see from this graph here that IV fluid dosing for sepsis resuscitation greater than 30 mL per kg was kind of associated with decreased risk of in-hospital mortality. And as far as the unadjusted p-value was concerned for ICU admission, you saw that the ICU admission in the normal saline group was higher as compared to the LR group. And then as far as the hospital length of stay was concerned, the LR group had higher hospital length of stay. So the evidence, again, is kind of like 50-50. There's no true signal from our data to show that LR was better as compared to normal saline. But as I mentioned, it makes physiological sense. And that's why when large volume resuscitation, we tend to use LR after the first bag or so of normal saline. And as far as the quantity of fluid resuscitation is concerned, as I mentioned, this is the same database, and we looked at whether 30 cc's or more or less than 30 cc's, because that is the controversial aspect of what I mentioned is the SEP1 metric. Everything else, some may agree with it, but this part is the standout. From our data, actually, we show that patients who actually receive 30 cc's or more of crystalloids, total of 2,300 plus patients, and doing a weighted analysis, the outcomes were actually better in patients who receive more fluids. I'm not saying to flood your patients and everybody should get 30 cc's per kg. There is a lot of clinical decision making that goes into it in this day and age of using ultrasound and other modalities to assess for volume status. I think individualizing the patients and assessing whether they need fluids, repeating that assessment after the resuscitation to see whether they are volume repleted or not, is the way to do the resuscitation for your septic patient. So coming to volume status, as I mentioned, assessing volume status in your patients is the most important part in terms of individualizing that care. And how do you assess for volume status at your institution? At our institution, we use point of care ultrasound. We look at IVC, LV contractility. Some use VEXIS. Then there are other modalities like checking for pulse pressure variability, looking at CVP, which is your standard old but tried and tested method. Leg raising test is another thing that we use. But I would like to add that no one test or method perfectly can predict the volume status. I think combining a couple of these tests or modalities is the ideal way to assess for volume status in your patient. Like to throw in, these are something that most of you are familiar with. Like to throw in estimated plasma volume status as something that I believe can throw a lot of potential. It has a lot of potential in terms of future of assessing for volume status. So what is plasma volume? We know plasma is a liquid that amounts to almost 55% of our blood volume. And some of the components of our blood plasma volume is water, dissolved protein, glucose, clotting factors, electrolytes, and so on and so forth. So it is something that is abundantly there in our blood volume. And how do we calculate plasma volume? So there are many formulas that actually measures or assesses for the plasma volume. So there is a Kaplan formula, the Strauss formula. The essence of calculating plasma volume status is simple. You need your body weight of the patient, you need hemoglobin and hematocrit. And whichever formula you use, you kind of stick to it and kind of use that consistently. And just one paper, and this is our patient cohort, same group that we looked at balance versus regular normal saline crystalloid and the 30 cc's versus less than 30 cc's of volume in terms of resuscitation. So this sepsis patient group, we kind of divided this group into two groups based on their median estimated plasma volume status. And we use the Strauss-derived formula, and we use the median of the group as a cutoff. And there were two groups. The group which had estimated plasma volume which was less than or equal to the median, or the other group which had plasma volume status which was more than the median. And this work was presented in one of the National Society, and this is an abstract. We were working on the manuscript, but you can look at the difference in terms of outcomes for the patients whose estimated plasma volume status was less than or equal to the median. And you look at in-hospital mortality versus hospital length of stay, ICU requirement, use of ventilator, all of those things were significantly lower in patients whose estimated plasma volume status was less than or equal to the median. So what can we interpret and how can we potentially use that in our clinical practice? I think there is need for prospective study to validate these results. maybe do the retrospective analysis in some other cohorts. But I think in real world, if we do a prospective trial and try to target resuscitation to a particular estimated plasma volume status, there could be a way that we can achieve resuscitation. Hemoglobin and hematocrit is a commonly available lab value, which most of our patients get on a routine basis. And with a simple formula, you can get to know their estimated plasma volume status very, very quickly. So there's potential here. There's something new and upcoming, and I just wanted to show it out there. Again, this is just an abstract presented at a society meeting. There is a peer review paper which should be coming out soon, so would let you guys follow that. What about timing of initiation of presses? This is another component of SEP1 metric, especially in patients who have septic shock, which was not responsive to the volume resuscitation. So the SEP1 metric says to start the presses within the first 6 hours. So where does this evidence stand in terms of timing of initiation of presses? So to illustrate the need or the importance of starting vasopressors, I want to show you this paper published in Journal of Clinical Care, which actually shows that delay in vasopressor initiation, which is starting vasopressor after 6 hours, showed that there was increase in 30-day mortality. This was a small cohort, small study, 76 patients in one group, which is presses within the 6 hours, and then 43 in the group wherein the presses were started after 6 hours. But I mean, the jury is out there. You would realize delay in vasopressor use, giving more fluid than needed, may actually cause mortality. So SEP1 metric, following that and starting the presses early is a wise move for your patient. Now, the question is, when you have to start presses, do we need a central line or can a peripheral line suffice? Do we need to wait for a central line before we start vasopressors, or can we start the vasopressor with a peripheral line and then, if need be, use a central line? I think we should not delay pressor initiation by waiting for a central line. If you need to start a vasopressor, start it through a peripheral line while you try to assess and get a central line. And when you get a central line, you can switch the pressors from peripheral to the central line. As far as the safety of the peripheral administration of vasopressor is concerned, I think this systemic review published in the Emergency Medicine Australasia journal kind of shows you that for 1,382 patients where they use peripheral pressors, the number of complications in that group of systemic review patients, the number of complications are very low. And also, as far as complications were concerned, there was very less number of patients who had extravasation. And as far as threatening limb ischemia or other complications are concerned, those were negligible. So when you're using peripheral vasopressors, I'm not saying just start and then forget about it. We need to be mindful. If you're using peripheral vasopressors, the most important part of using peripheral vasopressors through peripheral line is use the peripheral line in proximal large veins. Limit the use of pressors. You have to time it, saying if you need the pressors for more than 6, 12, 24 hours, you need to escalate, get a more secured line. Limit the max dose depending on the institution you're working. I would not go past 0.1 micrograms per kg per minute of norepinephrine or its equivalent dose and vasopressin or other things. If you're using multiple pressors peripherally, that may be risky. You need to have a monitoring algorithm of the peripheral line by the nursing and the bedside providers, and monitoring it to 30 minutes QR is important to watch for extravasation. And if the extravasation happens, you need to have a plan in terms of how do we take care of the extravasation with topical agents at your institution. So bottom line, peripheral vasopressor should be used as a bridge to either recovery, that is, if the need for pressors is very short term, that's fine. But if there is an escalation need for vasopressor, you need to switch to a triple lumen. Could be a PICC line, could be a midline, which some of the institutions are using, could be your IG or subclavian central line. Now, changing gears and looking at sepsis from a different lens. As SEP1 metric is telling us, we send cultures routinely as part of this bundle. How often do we get culture positive sepsis? And how does culture positive sepsis fare as compared to culture negative sepsis? Because that is important in terms of overall outcomes of septic patients. So to illustrate this fact, I want to show this paper which kind of compared these two groups, culture negative versus culture positive sepsis. And what it actually found was that as far as culture status is concerned, I mean, having the culture positive status would help in tailoring antibiotics, but as far as actual outcomes are concerned, after adjusting for severity of illness, the mortality between these two groups were actually similar. What is the most stark and important part is of the total number of patients, which was close to 10,000 odd patients, only around 11% of the patients had positive blood cultures. The 89% of these patients who had blood cultures sent had negative blood cultures. So vast majority of your patients would have negative blood cultures. We see that in our practice based on our data and our experience, that close to 10 or 15% of our patients would have positive blood cultures, rest would have negative blood cultures. But as you can see from this, the outcomes as far as mortality is concerned is similar in both those groups. So why is this case that why do very few blood cultures come back positive? And then, like, the reflection that these authors had based on their data was that the key reason for the culture negative sepsis was the use of antibiotics prior to their hospital admission or prior to drawing blood cultures in the preceding 48 hours. As I mentioned, the outcomes were equally bad between the both groups. So the age-old adage of like culture positive septic patients would do worse as compared to culture negative sepsis, I think the evidence says it otherwise. We need to pay attention, especially when antibiotic was used prior to their hospital admission. You may not have culture positive, and the outcomes would be similar. As far as use of midodrine is concerned, a really brief few slides to illustrate the fact that midodrine has been tried both early on in sepsis to avoid potentially pressors and later in the sepsis to get off vasopressors. So where does the data stand in terms of midodrine use? So this was a trial done at Mayo Clinic and our Rochester campus. This was just a very early small sample feasibility trial. Within the first 24 hours of sepsis, starting midodrine along with a vasopressor to show that it is well tolerated in the right group of patients and no serious adverse events were observed in this group of patients. The total number of patients in this trial is 32 patients. We are doing a larger trial to actually power it for outcomes benefit, and more to come in future about that trial. But at least what we showed was that it is feasible to use it without any major adverse effect, and outcomes were similar in both the groups as far as sepsis is concerned or the need for vasopressor is concerned. So some proof of concept in terms of use of midodrine early on. As far as, so this is like how this study used midodrine. This is not to replace your fluids or vasopressor, but starting it early so that potentially you can decrease the usage of vasopressors in the patient's care continuum. This is another review article which actually looked at all the trials which use midodrine in septic patients and was vasopressor sparing agent in septic shock. The data is kind of iffy. As you can see, it truly did not decrease the need for vasopressor in a longer term. It did not decrease the number of days of vasopressor. There were retrospective trials. 3 of the trials included in this review article was essentially retrospective. There was one randomized double-blinded placebo-controlled trial which did not show any difference in terms of IV vasopressor discontinuation, in terms of any significant advantage of using vasopressor, especially when you're weaning the vasopressors. The last topic that I want to touch upon is the inpatient sepsis identification. This area is very close to me. The reason being, for us inpatient providers, when we are trying to take care of a sepsis patient, identifying the sepsis patient, especially in an inpatient setting, for a patient who has been in a hospital for a few days, is a clinical blind spot. If a patient walks through the ED and is showing signs of sepsis, it is easier to identify, and appropriate measures like SEP1 metric is instituted and the outcomes are good. But what if a patient is already in the hospital for some other reason and then develops sepsis? That is where I think we struggle, and that's where potentially there could be technology and other tests could be utilized to do a better job in terms of identifying these patients. So sepsis detection, as I mentioned, there is a clinical blind spot, partly because there are a lot of mimickers, a lot of other conditions which can have a pro-inflammatory drive, which could also kind of mimic sepsis, and that becomes a conundrum for a clinician taking care of these patients. The other part which is tricky in these patients is when a patient is on a general ward, they may not receive as intensive of monitoring as they would get, especially in ICU or through the ED when they get in for the very first time. And the current biomarkers that we have are not really sensitive and specific enough. I think there is need to develop new biomarkers and newer tests which could help in detecting especially bacteremia or other infection quickly, so that we can turn around and institute antibiotics in a timely fashion. So that's where I think AI can certainly help in terms of detecting sepsis. Nowadays, with ChatGPT and all the other things going around, the mass hysteria around AI, you would say we probably should do a better job in terms of detecting sepsis. We, as a group, collectively have actually not done well in terms of identifying sepsis using models like AI. So this is a study which was done using Epic's sepsis model. So the very first model that they kind of created had close to 27,000 patients, and they're trying to utilize this AI tool to see whether they can detect sepsis early and whether they could institute care in a timely fashion. So as you can see, this chart actually shows the EPIC model actually detected sepsis in way less patients as compared to the actual patient who had sepsis. So of the total patients who had sepsis in that cohort of 2,500 or so patients, could only detect positive sepsis in 843 patients. 1,709 patients were missed by this tool. As far as false positive sepsis is concerned, they had sepsis detected in 6,128 patients as compared to total of 35,000 patients. So neither this tool was sensitive enough to detect sepsis. The worst thing we could do is miss patients with sepsis. And then it also had positive sepsis in way too many patients as compared to patients who did not have sepsis. So I think this is just an example. I believe they're working on a model too, which we hope to institute at Mayo Clinic, Florida, which is much more robust in terms of sensitivity and specificity. But collectively, as a scientific community, I think there is work to be done using AI and other tools, other biomarkers, and other tests to identify sepsis in an inpatient setting. I want to end with this article published by my colleagues at Mayo Rochester, Dr. Vitali, Pickering, and Dietrich. They published this last year in 2023 in ICU Management and Practice. And it kind of illustrates the point that I was trying to make, is why is artificial intelligence not fixing the problem of sepsis in the hospital setting? And they kind of list several of the important points that I raised. The question about accuracy, the lead time bias. It's our ability to implement and integrate it in our clinical workflow. The question about specificity and sensitivity of the model, validation, incorporating variability within the patient group, and need for continuous improvement. I think all those things need to be focused. So I want to end our presentation with this slide, which is focusing on what matters and keeping our eye on the ball. As far as sepsis care is concerned, at your institution, whatever criteria you use, whether it's SIRS criteria or QSOFA score, whether you follow all the components of SEP1 metric or not, what is important is identifying your patients with sepsis in a timely fashion and having an organized approach to taking care of their sepsis care, be it timely and appropriate antibiotics, providing them with resuscitation, assessing for volume status, and instituting pressors if need be in a timely fashion. These are the basic things which would help save lives, improve mortality and overall outcomes as far as sepsis is concerned at your institution. I will end here and see if you guys have any other questions. Thank you again.
Thank you, Dr. Sangavi. We appreciate your insight on the identification and treatment of sepsis. The artificial intelligence angle to sepsis identification is very intriguing. I'm sure that you and your colleagues will continue to make rapid progress in this area. Now let's hear from Dr. Dennis Begos to discuss fluid balance and ePV assessment in critical illness. Dennis?
Thanks, Rick, and I really want to thank Dr. Sangavi for an excellent presentation. He's really one of the key opinion leaders on managing the septic patient, and I thought he did a wonderful job of distilling a very complicated topic down to its essentials, which is very difficult to do in a 45-minute lecture. What I want to do today is discuss a particular aspect of managing septic patients, and that's using estimated plasma volume as a marker to manage the septic patient. And we know that plasma volume status really plays a critical role in multiple situations. And you can see from the figure on the right, it doesn't just affect the heart and the lungs or the kidneys like most people think of. Of course, it does affect those, but it really has an effect on just about every organ system, including the brain, the liver, the GI tract, and the skin and soft tissues, which can have a big effect on wound healing in patients with volume overload. We also know that accurate assessment of the patient's volume status is something that's notoriously difficult, but it's critical in determining treatment. So answering questions that we have to answer every day and managing patients, such as whether we need to diurese the patient, whether the patient needs fluid resuscitation, whether the patient needs pressors, basically is the patient on the wet side or on the dry side. We risk things like kidney injury for patients that are too dry or under-resuscitated, and we know that outcomes are worse in patients who develop fluid overload. And you can see here there are lots of different ways to assess plasma volume or measure plasma volume. You can see from very simple in the upper left clinical findings, such as just physical exam findings, jugular venous distension, vital signs. There's biochemical ways of assessing plasma volume. X-ray can be used, such as echocardiogram or just a a simple chest x-ray. There are non-invasive methods, and then there are the more invasive methods such as central venous pressure, pulmonary capillary wedge pressure, or various dilutional techniques. One thing that we can say for sure is that when there is such a large number of potential ways to measure something or assess something, it's that one of them doesn't really work or isn't the definitive method. So most clinicians use a combination of a lot of these measurement techniques to assess a patient's plasma volume. As Dr. Sangavi had mentioned, and as I'm going to talk about further here, is really in the past 10 years or so, the advent of plasma volume formulas has come into play in terms of assessing patients and developing a prognosis for patients, not so much managing patients day to day at this point. And we can break down plasma volume formulas into two big categories. There are several different formulas that are used, but you can divide them into two broad categories. One would be the Kaplan formula, which incorporates weight into the plasma volume calculation, and the other one is the Strauss formula, which just uses the hemoglobin and hematocrit. And so different clinicians and different researchers have used these formulas not so much interchangeably, but they basically get at the same root. And most researchers now seem to favor using the Strauss formula, which just uses the hemoglobin and hematocrit, because estimating a patient's dry weight can be somewhat difficult. You may also see other terms used for plasma volume, and they all are used somewhat interchangeably. So we talk about estimated plasma volume status, calculated plasma volume, change in plasma volume, or ideal plasma volume, and all those are again, used interchangeably. The formula that, like I said, is being used most frequently now by clinicians and researchers is the Strauss formula. Strauss formula was derived back in the 1950s, and it really measures the change in plasma volume over time. So looking at two different measurements of hemoglobin and hematocrit, and then calculating what the change in the plasma volume status is over time. Duarte in 2015 derived the Strauss formula to come up with an instantaneous plasma volume status, just using a single hemoglobin and hematocrit. So the advantages of this is that since it just uses hemoglobin and hematocrit, it's easy to calculate. It can also be calculated retrospectively from large data sets that may not have patients' weight available. It can be followed prospectively as an inpatient and even transition to outpatient use. And this can potentially help manage patients with various conditions such as heart failure and other issues where plasma volume is important. And again, the Strauss formula is easily done, it's fast, just relies on the hemoglobin and hematocrit. It's inexpensive. These patients are getting a hemoglobin and hematocrit drawn pretty much every day anyway. It can be used in a variety of different hospital settings, not just in the ICU, like some of the more invasive or intensive methods of measuring plasma volume status. It can be used on the floor, and then again, as I mentioned before, it can be transitioned to outpatient use. There's now a lot of data to support the use of the Strauss formula in managing patients and assessing prognosis in these patients. And you can see from this the image on the right, this is a screenshot from a Prime Plus looking at a hypothetical patient with heart failure who comes in with an elevated plasma volume, and as that patient is being treated and diuresed, the plasma volume goes down. And this is something, again, that can be trended easily on the device. And plasma volume is useful in many clinical scenarios. So the prototypical area where plasma volume has started to be used is in heart failure, which makes sense. Patients in heart failure get in trouble when they get volume overloaded. And more recently, it's been used to look at a lot of different conditions, such as sepsis, as we're going to talk more about here. There's data on ARDS prognosis using plasma volume, patients with kidney disease, COVID, and even all-cause mortality can be predicted somewhat by looking at plasma volume. The first group to really look at plasma volume in sort of the modern era was a group of cardiologists from France who started looking at plasma volume roughly around 2015. And this is a paper from 2018 from that group where they took 3 large studies on patients with heart failure and divided the patients into terciles based on their plasma volume status. And you can see in all the studies, patients who had the highest tercile of plasma volume had the poorest outcomes. They had more cumulative event percentage than patients with the in the lower 2 terciles. And again, this makes intuitive sense that patients with heart failure get into trouble when their plasma volume goes up. What's interesting and maybe not so intuitive is this study here from Marwan. They used data from the National Health and Nutrition Examination Survey, so over about a 15-year time period, over 42,000 patients, a longitudinal study, and they used the Strauss formula to calculate plasma volume in these patients. And they, again, separated the patients into quartiles based on their plasma volume status. And they found, not surprisingly, that cardiovascular mortality was higher in patients in the highest quartile. But what was somewhat surprising is that those patients in the highest quartile of plasma volume status also had a higher mortality from cancer and higher all-cause mortality. And you can see that in the curves here on the right. The first curve, again, shows the survival curves based on plasma volume quartile. And on the right, you can see a mortality rate based on plasma volume quartile. One of the first groups to look at plasma volume status in sepsis is Turcato, a group based in Italy. And he first looked at over 1,500 patients who just presented to the emergency department with fever. So these are patients not diagnosed with sepsis, patients just with fever. And he retrospectively evaluated their plasma volume status on admission using the Strauss formula. And he found that patients with an elevated plasma volume status, so greater than 4.52 in this particular group, which was the median, those patients had an almost twice the likelihood of having sepsis and about a 3 times likelihood of dying than patients with a plasma volume status of less than 4.52. He again then separated out just the septic patients, and this was a recently published paper just from last year, looking at 455 patients with a diagnosis of sepsis, and again looking at the Strauss calculation of the ePV on admission. Not surprisingly, patients with a higher, with an EPVS higher than the mean had a higher mortality, and the average EPVS in survivors was 5.19, whereas the EPVS in non-survivors was 5.74. And you can see the survival curve based on the plasma volume status being higher or lower than the mean on the right. What was interesting in this study is they found that EPVS seemed to be an independent predictor of mortality in patients who had a low Apache score. So patients who were not predicted to have a high mortality based on their Apache score had a higher mortality than anticipated. And we can look at that here. This is again, a flowchart from that study. If you look at the very topmost box, it's the 30-day mortality, and then that's divided up by Apache score as you come down. So to the left is an Apache score less than 12. To the right is an Apache score of greater than 14. And we can focus on this box down here, where they further subdivided patients with an Apache score of less than 12 into a low EPVS or a high EPVS. And we can zoom in on that and see that patients with a low Apache score, again, so a low predicted mortality, if they had a low EPVS, their mortality was indeed low, about 2.5%. Patients, however, with a higher than average EPVS had about a 14% mortality. So these are, again, patients who are not predicted to have a high mortality, but based on an elevated EPVS, their mortality was significantly higher than the group with a lower EPVS. And somewhat of a cousin to sepsis would be ARDS. So this is a study from Johns Hopkins, published in 2021, looking at patients with ARDS. And you can see in the graph on the left that as plasma volume goes up, so does mortality. And again, you can see in the survival curve on the right, patients with higher than median plasma volume had poorer outcomes than those with lower than the median plasma volume. And Dr. Sangavi's group published a similar study to this. This was in COVID patients with ARDS, and you can see, again, the curves are very similar to the previous slide, where you have mortality increasing as plasma volume increases in the graph on the left, and the survival curve on the right, again, showing that patients with a plasma volume status greater than the mean had poorer outcome and a higher mortality rate than those with plasma volume status lower than the mean. Another study looking at EPVS in COVID, over 5,000 patients, 5,800 patients from Croatia, again using the Strauss formula to calculate EPV. And the patients with a higher EPV had a higher mortality. They had a higher risk of bleeding or thrombotic complications. They had elevated cytokines and elevated D-dimer. So again, using EPV as a prognostic tool can be potentially very helpful in determining in either triaging patients or potentially determining care for these patients and prognosis for them. So to summarize EPV in managing sepsis, EPV is really a simple calculation using measured hemoglobin and measured hematocrit, which is a strong predictor of clinical outcomes in many different settings. It's important to know that many blood gas analyzers and other analyzers may just measure one of these variables, either hemoglobin or hematocrit, and then calculate the other based on that. The Nova Prime Plus does measure both hemoglobin and hematocrit. So when you have a formula with only two variables, it's important that they both be measured. EPV could identify patients with a worse prognosis, so that could be helpful for triage. It may also be helpful in patients who are not apparently ill by either clinical criteria or by something such as an Apache score or a SOFA score. And it's useful to think of it, I think, as more of a prognostic marker. It can be used as a measure of volume status and used for that purpose, but just independently as a prognostic marker, it does seem to carry some weight. The hope is that with more study, EPV could potentially be used to make real-time decisions and whether or not to diurese a patient, whether to give them volume, whether to start pressors is something that could be potentially very helpful in clinical decision making. So EPV is just another data point. It's not, again, a definitive measure of somebody's volume status, but it can be used to confirm one's clinical impression, whether a patient may be wet or dry. And it may, again, be helpful in clinical decision making as we gather more data on using EPV in real time. And prospective studies are really what's needed to better define its role in real-time clinical decision-making. Nova Biomedical makes an analyzer called the Prime Plus, which is a comprehensive critical care analyzer that will calculate the plasma volume from the H&H using the Strauss formula. And as you can see, it has a whole host of other parameters that it will measure, including a blood gas analysis, electrolytes, lactate, which is also obviously very useful in sepsis management, and co-oximetry. So it's really a useful analyzer for managing a patient with sepsis. With that, I want to thank you very much for your attention and for attending this webinar. I'd be happy to answer any questions that you might want to post through the portal. If you're watching this online after its live presentation, you can always email me at the email address that you see here with any questions that you might have. So thank you very much, and I will send it back to Rick.
Thank you, Dennis. Before we begin the question and answer session, I want to remind you to submit questions for Dr. Sangavi and Dr. Begos using the Q&A tab on your screen. Also, as a reminder, your continuing education certificates will be emailed once you complete the post-webinar survey. A link will be sent to you at the conclusion of this session. Now we have a few questions for Dr. Sangavi. So our first question is, do you see ePV as a marker to be used in real time to guide fluid management of patients, not just with sepsis, but with other conditions such as heart failure, ARDS, and others?
I certainly believe that ePV has a scope and potential. There have been other studies, mostly retrospective, in ARDS, especially we actually also did some ePV work for our COVID patients, which we had a very strong signal. There are heart failure patients where ePV has been studied as a volume assessment tool. But all those work has been, so far at least, in the retrospective realm. What needs to happen for it to kind of come to the mainstay of sepsis care or any other disease care is to have trials which actually validate it in a prospective fashion. The challenge right now, at least what we faced, was how do we identify the cutoff for the sepsis patient? What is the estimated plasma volume status that we target your resuscitation to? What we use in our retrospective work, as I showed on my slides, is we actually calculated the median, but that's not how it works in the real life, right? When you're taking care of one patient at a time, what is that cutoff that you would use to target your fluid resuscitation? That is where I think evidence needs to evolve further. And if we have trials which actually can validate that cutoff, that is where I think it would be used more so commonly in a day-to-day practice.
So for our next question, do you use any type of physiologic fluid status monitoring in your practice, such as bioimpedance, pulmonary capillary wedge pressure, or other types?
Our practice uses a lot of Swan-Ganz catheter. Our patient population is unique in terms of their hemodynamics, so we do use a lot of Swan-Ganz catheter. In certain select cases, we do have bioimpedance and other techniques that we use, but not regularly. But as I mentioned in my slides, I think no one tool is adequate to tell you the volume status of your patient. I think the clinical understanding of volume status needs to institute multiple tools, and it has to be done in a repeated fashion. So we have one value, either from ultrasound or wedge pressure or whatever else. We need to repeat it. If we diuresing a patient to de-resuscitate the patient, then we need to kind of measure the volume status again, understand what's the hemodynamics like. So repeating that and utilizing 1, 2, 3 multiple forms of clinical assessment. And this day and age, with use of ultrasound, it's become very common to kind of do a point of care ultrasound at the bedside, look at the heart, look at the lungs, IVC, straight leg grazing test is another thing. More advanced practitioners of ultrasound use VEXUS as another modality to assess for volume status, and using that after your intervention, be it fluid resuscitation or de-resuscitation, to see what impact it made to your patient, and then kind of recalibrating your strategy is how I would use various tools which are available for us.
Okay, thank you. Now for our next question. Do you think point-of-care testing for lactate is necessary for sepsis management in 2024?
As I mentioned, there are people within even our practice who don't like lactate. They think this is not an accurate assessment of perfusion of the patient. But as I mentioned, what we had before lactate alongside was mixed venous saturation. What is that next test that would kind of mitigate some of the concerns that are around for lactate? Right now, as evidence stands, we do not have a better tool than lactate. Lactate is not ideal, but still does the job. And that's why we use it in our practice. SEP1 metric has that as one of the tools, and kind of clearing lactate as some of one of the endpoints or objective of resuscitation in a septic patient. But I would completely agree for the naysayers that that's not an ideal tool. But there's a need for one. Some say renin is, some say there are other ways that we can kind of figure that out. It's not ready for real primetime use. So point of care lactate remains our best bet, even in 2024.
All right, so we have time for one more question. So you have noted that lactate is a marker for tissue perfusion that can help guide treatment in sepsis. What other markers could be used in combination with lactate to fine-tune the diagnosis? Possibly electrolytes or EPV?
As shown in my slides, blood culture is something that we kind of base our treatment, right? The first step we say is do cultures, then start antibiotics. But as I showed, like only around 10-15% of our cultures come back positive. We know that lactate is not an accurate metric measurement of volume status or perfusion in a patient, but that's kind of the best thing we have so far. Along with that, I think, so you have to distribute or divide this question into what are the diagnostic tests that are around. There are several molecular DNA-based tests which are in the horizon, which probably would do a better job than blood cultures in identifying which organism is causing the sepsis. Because right now what we have for majority of the institution is only blood cultures. But the need of the hour for diagnosis is something which is rapid, which is available at a very cheap, in a cost-effective way, and the turnaround time is quick enough to calibrate or recalibrate your antimicrobial use. So that's for diagnosis. For volume assessment, as I mentioned, one test or modality is enough, and there is potentially a scope for cheaper, user-friendly modalities like, say, estimated plasma volume to understand and resuscitate the patients better. I don't believe estimated plasma volume alone would do the job. I think along with other things that would play some role in terms of doing that, but more data, more work needs to be done to prove that, whether that stands the time in the test of prospective trials.
Okay, thank you to our audience for those excellent questions. We'll conclude the webinar at this point, but be sure to join us again and invite your colleagues to attend the next Nova Biomedical educational webinar. You can register at novabiomedical.com/webinars, where you will also find a full catalog of on-demand webinar offerings. So for Dr. Sangavi and Dr. Begos, I want to thank you for your interest and attention, and enjoy the rest of your day.